Good morning, everyone, and welcome to day 3 of this year's Children's Week virtual conference. I'm Dr. Ruth Adewuya. I'm the Managing Director for the Stanford Center for Continuing Medical Education, and I am so pleased that you were able to join us for this morning's session. Before we get started, a few housekeeping notes. First is that this session is awarding both CME and ANCC credits. There's nothing for you to do at the moment. You'll receive an email tomorrow from our office with instructions on how you can avail of those credits if you are interested. Today's session is going to be a rich discussion on supporting the healthcare transition from adolescence to adulthood. And we have a great lineup of speakers with us today that I'm happy to do brief introductions. So we'll start off with Lindsay Barkoff, who is a pediatric heart transplant nurse practitioner who completed her training at Columbia University School of Nursing and is part of our team here at the Children's Hospital. Mary Helmers earned her degree from the University of San Francisco and is currently the pediatric cystic fibrosis nurse coordinator. And she has been at Packard for 38 years and sits on a national committee for transition. Teresa Priestley is part of the social services care team. She has been a parent educator for almost 20 years. She has extensive experience working with parents and children who have experienced trauma and or separation. And one of the main objectives of her work is to empower parents to help their children heal from pain and trauma that they have experienced. And then lastly, Pam Simon has a 30-year nursing career where her expertise has been in pediatric and adolescent oncology. As a nurse practitioner, she's found her passion with the AYA cancer population, and in 2015, launched the Stanford Adolescent and Young Adult Cancer Program. She completed an online master's certificate in teenage and young adult cancer care through Coventry University in London and continues to work to improve the care for this underserved population at a local, regional, and national level. I am so grateful that this group has agreed to speak with us this morning. Throughout the session, please put your questions for them in the Q&A portion of your Zoom. So in the bottom of your screen, you'll see a Q&A button. That's where you'll want to ask all of the questions, and they'll spend some time during the session answering those questions as well. And so with that, I'll turn it over to our speakers for this morning.
Good morning, everybody. My name is Mary Helmers. Thank you, Dr. Adewuya, for the introduction. Our talk today from all the presenters is on supporting the healthcare transition from adolescence to adulthood. My personal presentation will be on the Stanford cystic fibrosis pediatric to adult transition process. I'd like to do a little bit of introduction first for all the speakers in our presentation. Myself, who is the pediatric cystic fibrosis nurse coordinator here at Stanford Children's. Teresa Priestley is a social worker that works in our Emeryville site. She does CF and pulmonary there. Teresa also works in our Monterey and Capitola clinics in all specialties. And here in Palo Alto, she also covers relief for specialty clinics as a social worker. Lindsay Barkoff is a pediatric nurse practitioner for the pediatric heart transplant coordinator. Pam Simon is a pediatric nurse practitioner for Oncology Bass Center, and she also is on the Stanford Adolescent and Young Adult Cancer Program. I'd like to welcome all of them to our presentation as well today. So the objectives for my talk will be to define transition and transfer, understand the importance of transition for patients with chronic disease. It is the hope that you can describe the transition process on Stanford Children's for cystic fibrosis patients and discuss educational approaches used in transition. Now, although my talk is directed towards cystic fibrosis, since that is my expertise, anything that I talk about today can be utilized for other disease states, and I would highly encourage you to maybe utilize that if you're looking for a transition program. A little bit about our CF program here at Stanford. The program is accredited by the Cystic Fibrosis Foundation. The Cystic Fibrosis Foundation is similar to like a joint commission who accredits hospitals. The CFF accredits cystic fibrosis centers, and there's several throughout the United States. We have 209 pediatric patients. We have 8 pediatric pulmonologists who cover and see and take care of our CF patients on the ped side. We have 1 nurse practitioner who's the head of our newborn screening program. We have 6 pulmonary fellows, 1 nurse coordinator, and 1 part-time CF clinic nurse. Our adult program, we have 204 patients, so just slightly less than the ped side, 2 pulmonologists, 3 nurse practitioners, 1 pulmonary fellow, and 2 nurse coordinators. So why transition or transfer? And what is transition and transfer? Transition, the definition of transition can be found as the purposeful, planned movement of adolescents and young adults from pediatric care to adult care. Here at Stanford CF Center, transition is when our patients move from pediatric CF care to adult care safely and smoothly. And in 2000, the Cystic Fibrosis Foundation mandated that all centers have a pediatric program and an adult program. Thus, the need for transition became even more apparent. Transition is a normal milestone that patients and families will experience. As these patients are living longer in this disease state, we need adult programs. The CF Center Care Team is committed to caring for people with CF across their lifespan. Helping young adults and their families move to the adult care team is part of our strong commitment. Transfer is the point in time in which the patient moves from the pediatric care center to an adult care center. So why transition? Again, as stated, the CF Foundation mandated pediatric and adult programs, which meant that we needed to separate out peds and adult patients from being in the same clinics and even being hospitalized together. They were living longer and they found the need that we needed to have adult programs. The transition from a pediatric to adult health system is a vulnerable time for young adult patients with chronic diseases, not just in CF. Treatment advances in CF have led us to an aging population and a growing number of adult individuals, and there's a compelling need for specialized health care across all age ranges. We have seen our young adults grow up, go to college, get jobs, get married, and have families of their own. It is our hope that time spent in the pediatric center prepares these patients for life as an independent, healthy adult. I can tell you that when I started here in February of 1985, a long time ago, these patients did not live past 30 years of age. Maybe we had a few handfuls in their 40s. We now have patients well into their 70s and 80s. The transfer of care process at the Stanford CF Center was variable and highly provider dependent. From 2017 to 2019, you can see that we only had 14 transition patients. We found that the average FEV1 decline of 6.8% happened when patients transferred over to the adult program. And usually the first adult visit with the adult team took about almost 3 months. So what led us to transition? As stated, the median age of survival increased yearly. When I started here, the median age of survival was between 18 and 21. And you will see down below that it's now 50 years of age, which is huge. With age comes adult issues that pediatricians were not trained to recognize and treat. Cystic fibrosis was always known as a pediatric disease. Now it is known as a disease throughout the lifespan. Before transition, CF centers had combined pediatric and adult programs. The CF nurse took care of all patients, as I did when I first started here. As I said, patients were in the same room. I remember at the old Chaz, which doesn't even exist anymore, you had an adult 30-year-old, maybe a 2-year-old, and a 15-year-old all in the same room. Pediatric and adult patients were hospitalized all together, which did have its benefits before isolation policies came out, because the younger ones watched the older ones do their treatments, and it was kind of a learning. They were learned by example by the older patients. Since transition, though, CF centers have separate programs. CF nurse take care of either the pediatric or the adult patient. Median age of survival is now 50 years of age, and adult CF patients will eventually outnumber pediatric. Here at Stanford, we're pretty neck and neck, but in other centers, the adults do outweigh the pediatric population. So back in June of 2000, when this foundation mandated adult and pediatric programs, we had to start a transition process. At that time, To assist with transition teaching at our center, we developed a transition booklet. The booklet you see on your screen here is actually an updated version, which I did a year ago. But prior to that, the booklet was very similar. The booklet included an introduction, what it meant to transition and transfer your care. We defined it. We set up our booklet into stages. Starting at age 8, all pediatric patients will be handed the booklet with their parents. The stages go from 1 to 6 and are age dependent. It's to help them prepare for transition. Questions and answers about transition are in the booklet. When is it time to transition? And miscellaneous forms being contact lists from all the adult side, the pediatric side, and are also our adult counterpart at CPMC. If a patient chose to transition or transfer care to another center, they would develop their own transition program at their new center, but we would continue teaching them prior to them leaving our center. Here's a little bit more pictures of the booklet. As you can see inside, stage 1 is age 8 to 10. It's a checklist underneath that. It talks about patients start learning about their disease. We picked age 8, which seems to be standard across the board at most centers. When kids are starting to go to school and able to learn and read and write, they're going in and learning about their CF. Again, we encourage patients to bring these booklets at all their clinic visits. In a real world, that does not happen. In a perfect world, it would be great if they did, but at least we try to acknowledge and teach something at every visit. Clinic times are usually compacted, very busy, but we use this as a guide and a tool to help us get the teaching in that they need over their lifespan. So when they do transition later on, they have education and knowledge about their disease. So when to transition? Always the question. The CF care team looks at all patients that are between 16 and 21 years of age to determine the readiness of the patient to transition once they turn 18. Keep in mind, though, that there's also a parent transition as well. And a lot of times our patients are ready, but the parents aren't. So you have to also include parents in part of the transition, a very key point. Typically, transition occurs here at Packard between 18 and 21 years of age. The reason we have actually held off closer to 21 is because now our patients are going to college and they're having normal life events. And so going to college can be a huge transition in itself, going away from home, a lot of them do now. They're not just staying close to home or going to community colleges. So they prefer to wait to not have two big events happen in their lives. The pediatric and adult care teams meet quarterly to discuss patients that are ready to transition, and a detailed outline of patients' history is discussed. And I'll go into that a little more in a bit. So as stated, in June of 2000, when the foundation mandated adult and peds programs, we started to develop our own transition program. Pretty much blindsided back then because transition wasn't even a word that was discussed, especially in a CF center. We were doing pretty good, but we had some bumps in the roads because of changes on both peds and adult side staffing turnover, especially on our adult program at Stanford. We have the benefit of having an adult center right across the street from us. Other CF centers throughout the United States may have them a few miles away, 10 miles away, so it has a bit more challenges. But we have our adult program right at Stanford University. So about 4 years ago, we had an adult fellow and a peds fellow from pulmonary that decided to do a QI initiative project on looking at our transition process and seeing how we can improve it, because there's always room for growth. We did a root cause analysis and looked at our transition process, which seemed to actually be quite fragmented. Here we thought we were doing really well, but we had some bumps in the roads that we needed to fix. There was variable ages at time of transition, the patients. Some were medically and socially complex, so some may not necessarily be able to move because they had other diseases and complex care things that needed to be addressed. Providers, there wasn't always continuity of providers, especially on the adult side. Different management on pediatric and adult. When you're on adult side, you're treated like an adult, and on peds, not that you're treated like a child or a baby, even at 18, but there is more hand-holding on the peds side. So we had to learn how we could start letting go on our side, as well as encouraging them to increase their adult and being able to speak on their own. Our process, we had process, but it wasn't formal. And so we decided we needed to have a more formal assessment of our transition readiness for these patients. Information sharing is not standardized. 2 different facilities, 2 different EMRs. We both have Epic, but they couldn't speak to each other, which also was a problem, and 2 different hospitals where they would be admitted. Social, the insurance may change. State-funded insurance can pose a problem, and even private insurances, unpredictable parent support. Again, parents, some of them did not want to transition their patients because they weren't ready, but the kids were ready. So we had to work with both family and patient. So the key drivers in all of this when we were looking at everything was a consensus around who and when do we transfer. We had to come up with an age when we would start talking about these patients. The information was disseminated if it was inefficient in both centers. So we had to come up with a report that both could see and we could gather the information from both sides. Our investment was for our patients and families and our providers. We were committed. Preservation, we used FEV1s as our drive to look at how patients did when they transferred over to adult programs. It was clearly stated in many papers that patients, when they transferred to adult programs, there was a decline in health, especially FEV1s. FEV1 is a lung function that we monitor on patients to see how well they're doing. And this was going to be our factor that we used in deciding how to see how our patients did when they transitioned to the adult site. And education. We needed to make sure that we were educating our patients and preparing them to get ready to be on their own and independent in their care for their CF, especially since they are living longer now and having normal lifespans. So we redefined our program. We still do the transition booklet given to parents and patients at age 8. Education of patients and families is ongoing and it formally starts at age 8. However, when the first patient comes in at their newborn visit with Dr. Jackie Spano, our patients are getting educated right from the start. Well, their parents are getting educated. Patients just there, but we are starting education when their first day through our clinic. We have quarterly transition Zoom meetings with both peds and adult CF teams to review patients 16 and older. We lowered it down to 16. We did start at 17, but we have changed it to 16. And COVID actually started our Zoom meetings, which have worked out great. We have both pediatric and adults come every 3 months on Zoom meetings, and we discuss patients that are between 16 and 21 that are ready to transition. And then once a year, we discuss those patients that have transitioned in the past year, what went well, what we could have done better, and learn from our mistakes to make it better for other patients. Consensus is reached when to transition patients, individualized for each young adult. So at our quarterly transition meeting, that's the reason we start at 16, because there are some patients who have asked us to move to the adult side right at 18. We discuss it at our meeting and see how we feel and if they are ready to transition. And if they're not ready, we still have 2 years to get them ready. Preparing for transition during the final year at the pediatric clinic, we have a virtual meeting with the adult CF team members and peds patients and families. So basically this means that the pediatric team at the clinic visit, we have a Zoom link that the adult team members log in and hear the visit with patients and families on the peds side. This has proven really to be a really great thing. And again, with COVID, instead of having a lot of people in the room, we have a virtual visit, and it's worked very well. We have an interdisciplinary transition report, which I will show you, that's generated in Epic by myself, and the ancillary team. Then the adult CF team and/or adult provider come to our last pediatric visit. So if we've proven to see that the patient is ready at, say, age 19, it's been the year before they've had their virtual visits every 3 months because patients here need to come quarterly. On their last visit, the adult team comes in person to meet them in person, give them the laydown of what they will expect, develop a plan, connect them to MyHealth, make sure insurance is already taken care of, an officer in place, referrals have been placed for the patient to then smoothly transition and transfer care to the adult program. At this time, the patient gets an appointment, so that way, lastly, the pediatric team knows, so we can attend their first visit on the adult side. We just had a last visit 2 weeks ago for one of our patients, and I just got an email yesterday that in a few weeks on July 7th, he will have his first visit. We really try to get them into the adult side within the month or 6 weeks of their last visit on the peds side. That's our process now. So our current state, in 2019, 9 patients transitioned. In 2020, we had 3. Obviously, COVID slowed down a few things. In 2021, we had 6. Looking forward, this year, 18 pediatric patients and older, 16 and older, are to be reviewed and discussed for transition at our quarterly meetings. We have done an amazing job to turn this around. Our adult counterparts are extremely helpful in guiding us and getting our patients ready for transition. We still have more to grow on, but I think we're in a good state. So the transition reports in EPIC, this is vital. And we were trying to find a way, because we do have 2 separate EMRs that don't talk to each other very well. How can we get a summary of all these years of our pediatric patients into EPIC? So with the help of a great analyst, we made a CF report. This is where the ancillary team gets to write their notes. So the nutritionist, the social worker, myself, the respiratory therapist, and it doesn't show on here, but we also have a pharmacist. The pharmacist can write a note, which then will pull into this big transition report. This is an EPIC. And before the patient's last pediatric visit, I go in and fill out all the information. And it does pull in a lot, but it can be utilized obviously in any disease specialty, not just CF. But it's a great report that then gets put into the system. The adults can see it on their system in EPIC, but we also print it off and hand it to them. It's a great tool for them. So when they have their first visit on the adult side, it's basically like a little mini medical record for them to see everything that's gone on, and especially in the last year or 2 in the pediatric side. So to make successful transition, you have to have a successful educational toolkit or background, or some type of way of educating your patients and families to get them ready to be even more independent in their care. I've sat on a national committee for about 13 years. The foundation now has taken it over and has marked their stamp on approval of it. The national committee was called CF RISE, RISE standing for Responsibility, Independence, Self-Care, and Education. The background commenced at 2011 in our Northern American Cystic Fibrosis Conference. 10 centers were participating in the program, Stanford being one of them, and myself sitting on that. Pediatric adult patients and parents previewed the program, and we started it in 2013, so almost 9 years ago. The mission of the program was to foster patient ownership of CF care through an educational program focused on the achievement of independence. The objectives were to provide care teams with patient tools to help manage transition and transfer, help to facilitate communication between pediatric and adult care teams, patients, parents, and caregivers. Because when we did our track questionnaire during our QI study, we found that patients felt when they transitioned over to the adult side, they didn't feel like peds and adults were communicating with each other. This program has been extremely helpful in many centers across the United States. It's also a program that can be utilized in any disease entity, and I'll go into that a little more. The landscape of CF transition and transfer was, again, because we saw a growing number of adults. We found that there were gaps in transfer and transition related to clinical care that have been studied and identified. As I stated, FEV1s had dropped. Patients didn't come back to clinics for a while, or months, and even a year, because they just didn't make their appointments. The emerging adult, 18 to 25, is a huge at-risk group of patients in CF. So this national program that I was on, the booklets went originally from 16 to 25 was the transition educational program. It now is down to 10 and goes through 25. Basically, the goal is that you can get into the adult program and your transition and your education continues on. Though commonly discussed, no approach to facilitate this process has been made available nationally. This is the tool binder, which has all the program materials. It is also digital now. Quick assessment of the different types of knowledge, skills, knowledge testing that you can do on patients, skills checklist to see what they know, a progress report, and an educational resource guide. In summary, transition is an important aspect in the management of patients with chronic disease. Stanford Children's Cystic Fibrosis Center has established a transition program, and educational tool sets can assist in the transition process from pediatric to adults, which I didn't touch on only briefly. But if you want more information on CF RISE, again, Spark Healthcare is the one who designed and created the educational toolkit. You can contact Sonia Markovich at this email and number. And thank you very much. Please put your questions in the Q&A box.
Great. Thank you, Mary. So hi again, my name is Teresa Priestley, and I am a social worker here at Stanford Children's. And I have a little bit of a unique perspective because I have worked in the cystic fibrosis and pulmonary clinics primarily while I've been at Stanford, but I also have been providing coverage to pretty much every specialty at Stanford. And so kind of have a broad social work perspective on transitioning to adult care. So I thought that this little quote was pretty funny. Adulthood is like the vet, and we're all the dogs that were excited for the car ride until we realize where we're going. So I think that this can apply both to our patients who are becoming adults, as well as to ourselves as providers. So, you know, I think sometimes we're really excited about the idea of patients transitioning. It means they're adults. It means we've gotten them to adulthood. But then sometimes we have kind of some mixed feelings about actually sending them off. So I thought that was pretty funny. But we're going to talk about 5 kind of main things. One is kind of being able to say goodbye, transition timing, talking with families about transition, documenting transition, and social complexities and kind of how that can impact transition. So some people just can't let go. We sometimes have a hard time with saying goodbye to our patients. And, you know, that can be a good thing, because really what it means is one of the things that can make us such great providers is that we care a lot about our patients and the families we're working with. We know them really well. We've been through ups and downs with them. We've been through all kinds of stuff with them. But that also can make it hard to say goodbye sometimes. And so it is, you know, it can make it hard. It's a little like a parent sending their child off to college sometimes. And, you know, it also, one of the other things that can affect that when we send patients off is kind of how we feel about who we're sending them to. And that really can happen in any field and at any time. You know, a lot of times we feel like we can start feeling like, you know, I have provided so much for this family. I know them so well. They trust me. And we sometimes worry about sending them to somebody else and how they're going to do, and if that person's going to take as good of care of them and things like that. Unfortunately, when we have those feelings, oftentimes we unintentionally transmit that to families. And what it can lead to is families feeling a little bit more nervous about transition then. And often they're already worried about transition because they do trust us. They've been working with their pediatric provider for a long time. And the idea of going to someone new is a little bit scary. And so, you know, I have, in talking with various adult teams, you know, sometimes I've heard that they see patients coming in expecting that they're not going to like adult care, that they're not going to like being on, you know, being in the adult medical world. And, I think we end up kind of doing our families a little bit of a disservice when we go into it with some of those mixed feelings. So, some of the things that can help with that are making sure that we've been preparing our families and patients to be independent over a long period of time, so that we can feel good about them going to adult care. We're not feeling worried about, whether they're going to make it. Starting that process early, like I said, giving them a lot of time to learn these things and become independent. And then I think it really helps to have something where you celebrate the transition. And one of the things that I really love that Mary and the adult team had created with the CF clinic is they, families, when patients were ready to transition, they would get a card that everybody on the team had signed saying congratulations, and they'd get a little bottle of sparkling apple cider. And, it was kind of can be a little bit of a celebration. And I think it's really great when we can create something like that makes it feel like a really positive thing, instead of feeling like we're sort of the parent on the preschool yard that's, sort of giving a tearful goodbye as we tell our child that they're going to be okay. So I think having that celebration is really helpful. So transition timing. It's really helpful to have a process and have a specific time that we transition patients. I've worked in clinics where sometimes there's still patients there and they're 25 or 26. And we have to really look at why are we holding on to them for that long. And the reverse can be true too. Sometimes we're transitioning a patient at 18 because they're really have been hard to work with, right? Or they don't want to listen to us. They don't seem to want to take the advice and the coaching that we're giving them. And so we kind of, I think sometimes on the pediatric side, I've seen it in many clinics. Sometimes we justify to ourselves, well, they don't really want all the coddling that we're giving them. I think they'd like it better on the adult side where they're not going to get so much coddling, right? And I have to admit that I've been guilty of sometimes thinking that myself. So I think we have to really look at why are we choosing to transition a patient or not transition a patient. And, so again, with that, it can really help to have a specific time frame of when you do transition patients. In California, for patients who have Medi-Cal and are in the specialty clinics, oftentimes they have California Children's Services Insurance, so CCS, not to be confused with CPS. And so that CCS insurance ends at 21, which creates an excellent time for transitioning patients because adult providers often, generally speaking, don't take CCS. And so it can be a good break, right? Like, well, we don't take your insurance anymore after this age. So then you really need to go off to the adult care, right? Another natural transition can be going to college. Oftentimes, as Mary said, people kind of don't want to change providers multiple times. Sometimes they're not sure if where they're going to college is actually where they're going to stay. So they kind of wait until after college to transition. But, it helps to have kind of something that is sort of a natural transition time. And, part of the reason kind of having a timing in place is really important, as well as having prepared patients for a long time leading up to the transition is really important, is we don't want a crisis to happen that forces transition before, so that it feels rushed and maybe the patient's not really ready. One of the, we had a patient that was in past 21 and she ended up getting pregnant unexpectedly. And it ended up being a very abrupt transition because the pediatric side won't take care of pregnant women. So she needed to go to the adult side where she could be more appropriately cared for. But sometimes, you know, if we haven't been preparing people for that transition, it can feel very abrupt, and it doesn't feel like as good. It doesn't feel as good to either the person sending off the patient or the person who's receiving the patient. I have to say, I love this photo. If you're an adult, you can schedule your own appointments now. I feel like that's the face that most of our teenagers make when we tell them they need to start calling the clinic on their own. So when we are talking with families about transition, starting that conversation early is really important, and continuing to have the conversation, right? Not just mentioning it once, but that we keep talking about it. For me personally, not to say that the way I do it is the best way or the only way, but what I like to do is around the time that patients are, I actually start asking when they're toddlers, but really like preschool age. I start every year when I'm talking with families, we are sure to talk about, I ask them, you know, does the patient know what medications they take? Do they know why they take the medications? Do they know what the medication does for them? Do they talk to their friends about having this disease? Are they comfortable doing their care in front of their friends? You know, those kinds of things. And when I ask these questions, I make sure to tell families, I'm not saying this because I'm not asking these questions as a quiz. You're not being graded. There's no, you know, right or wrong answer to these, but I'm asking because these are important things to start thinking about. As you get older, you're eventually going to be, you know, independent, and you're going to be not, you know, as a teenager, you're not going to be at home as much. You know, eventually you're going to go off to college, you're going to get a job, you're going to live on your own. And these are important things for you to know by the time you leave. And we like for you to start thinking about them early so that you're not trying to cram in all this learning about your health, you know, in a short period of time right before you leave the house. You know, that's one less stressful thing, right? By the time you go off and you're moving out of your house, I want you to feel like you have this and it's easy for you. Like it's not something it's stressful and you're just trying to learn as you're leaving the house. So there's different ways, obviously you can bring up that conversation. That's kind of how I like to do it. It tends to feel less threatening for families. You're not saying, I want to talk to you about transition. Sometimes when you say transition, it can sound like a bad word to some families. They feel, you know, like you're trying to get rid of them, or, you know, why are we talking about this? My child's not old enough. So, you know, how we talk about it is really important. Also, you know, I've had families, I have one family who the mom, the way she interpreted a conversation she had with another provider at another center was that the provider had told her, when you turn 21, we're done with you. We're not doing anything for you. We're not giving you formula anymore. That her child was almost 21, but had had a non-accidental trauma as an infant and has pretty profound delays and is all G-tube fed. So mom was understandably kind of terrified when she heard this, because she said, oh my gosh, like, what if I can't get into a provider? Like, what happens if I run out of formula before I'm able to see somebody? And she was really pretty stressed about it, and hadn't felt like she, I guess, could kind of ask those things of the provider. So how we say these things is really important, so families don't feel like we're just kicking them out the door. And I don't think that is how that provider intended that to come across. But you know, how our patients interpret these things can, you know, it's not always the way what we say. They don't always take the way we intended, but just being aware of how we're saying it and how scary that transition is oftentimes for families. And, you know, having the conversation early is very important, because I have a family right now who has been trying to get the Medi-Cal converted for their 2 kids they have who they have conservatorship for. They've been working for over a year to get them all switched to adults, Medi-Cal and SSI, and providers and are just having one heck of a time. And that's pretty extreme. It doesn't normally take people that long, but really, I think it's important to have people start it early, not, oftentimes, especially when we have young people who maybe don't have as much parental support. Sometimes, we're not helping guide them with it early enough. And I'm guilty of this myself, but we, end up 2 months before they turn 21, we're like, oh yeah, you should change your insurance, right? We need to make sure we're helping them with that process early on. And when I do talk with families about transition, I try to really keep the focus on, like I said before, about wanting you to feel independent, wanting you to feel confident, wanting you to feel like you are knowledgeable about your care, about your condition. One of the things that I also ask teens is I say, do you feel like if you went to a new doctor, you could explain your medical condition to them and you could tell them all of your medications and why you take those medications? If you were out and got injured and you ended up in the emergency room, would you be able to tell the emergency room doctor all about your medical conditions? And so kind of helping them think about what are the different scenarios they might have to talk about these things in, as well as one of the reasons I ask about do they tell their friends is as they're going out with friends more, they might get in a medical situation when they're with their friends, and it's important that they at least have 1 or 2 close friends they trust who know about their medical condition and could tell somebody else about what might be happening with them or might be able to help them if for instance they're diabetic and they are having a low, having somebody there who knows and can help. I also think it's good to really sell transition. So one of the things I like to do is, for instance, when I have a teen patient who's thinking about college, they're getting a job, things like that, and they have questions for me about things that are really related to like working while you have a chronic medical condition, legal protections for them, things like that. I tell them like, okay, I know a little bit and I can give you some information, but one of the great things when you do go to adult care is that the people you're going to be working with there, their specialty is working with adults who are in school, who are working, and they really have a lot of experience with managing these kinds of situations and these issues and these questions that you have. They're really the experts in it. I know some things, but they're going to be able to help you with this so much better than I can. And so I like to really try to kind of sell the adult, that transition to adulthood as going to people who are experts in this stage of your life care. And I think that can really be helpful. And I've seen it really help patients who are feeling really reticent about transition. And I start saying that, and they start as they're asking me more questions about those kinds of things, I see them feeling more excited about, oh yeah, like I'm going to be able to go work with people who are familiar with these things that I'm going through right now. So I think it's important not only that we talk about transition with families, but that we have some way of documenting their transition readiness. And so one of the nurses that I'm working with right now has, dot phrases for, that's just a checklist of like basic things that patients should know at different ages and kind of can check off. Do they know that, right? And that way, it's in there, and if it's part of your regular documentation, then you're also more likely to remember to talk about those things, as well as remember where patients are at with their transition readiness, and so that you can continue to work on those things. So the things that, like I had mentioned earlier when I talk with families about transition, these are some of the things that I have built into my documentation. I don't have it in every note, but for sure in my annual notes, their knowledge of their condition, their knowledge of their medications, their ability to get refills or deal with insurance, the pharmacy, DME, these kinds of things. So that is really helpful. Having checklists that are simple can be helpful. As we all know, the more paragraphs we have to read through, the more the less likely people are going to read it. So if it's a checklist and it's easy to see, then it's just easy to, go through. Also, I appreciated this HIPAA knock knock joke. I thought that was pretty funny. So social complexities and transition. I prefer to describe myself as delightfully difficult, and it would just be easier if you agreed. Social complexities, a lot of this comes to us in social work, and who says social work is stressful? I'm 36 and I feel great. So again, going back to why are we transitioning a patient? Why are we choosing to transition them? Are we choosing to transition them because we think they're difficult? I have a patient who is 19 and is pretty sick, is pretty also tired of doing their care, tired of dealing with all the medical systems, tired of dealing with all the questions they get when they come to clinic, tired of being told what to do. Very understandably, he has to do a lot of care, and it's really taken over his life. And there's a lot of other traumas and things that have happened as well. But it can feel frustrating for the medical team to deal with helping him, because it can feel to the medical team like he doesn't really want to be helped, right? He doesn't want to have to go over his medications every time he comes in. He doesn't want to stay in the hospital as long as we want him to stay in the hospital. Just, all the things that are difficult as providers to deal with when we have patients who really just don't want to do those things. On the pediatric side, we were like, well, he really doesn't want to do all these things we're telling him to do. Maybe he'd do better on the adult side, where he can feel like, maybe he'll have a little more autonomy in what he does, and they're used to dealing with adults, as opposed to on the pediatric side, we're kind of more used to dealing with the parents and kind of being able to tell them a little bit more what they need to do. In talking with the adult side and asking them like, hey, do you think that this patient would be better served by you? Maybe maybe the adult side is going to be more understanding of some of these things he doesn't want to do. And they said no. So I think that sometimes as pediatric providers, it's important to remember that the adult side also doesn't necessarily want to deal with the same things that we don't want to deal with, right? So kind of being aware of where you're transitioning those patients to, right? Maybe the adult team that I spoke with would really not be an appropriate place for him to transition to. There's a lot of reasons it might not be appropriate for him to transition, but finding an adult team that is providing, that can provide the kind of care that that patient wants, talking with other kind of parents of adults who have cystic fibrosis. And, I've had them describe situations where, their adult child was going to one place and they felt like that one place just was not meeting their needs. They weren't working with them. They weren't taking into consideration the things that that patient found to be really important. And so they transitioned to a different adult care team at a different center where they felt much better supported. And so I think that, it's really important to keep in mind, like, where are we transitioning them to, making sure that it's a good fit for them, and making sure that they really feel ready and actually prepared for what they're going to experience on the adult side, right? And that we're, being realistic about that ourselves. It also, is one of the things that is difficult when there's socially complex families is we can tend to forget about issues related to transition. We tend to forget to talk about them because there's so many other things going on. Maybe they're, not taking their medication, they're not doing treatments, they're not doing the things they're supposed to be doing, they're homeless, they're, have chronic food shortage. There can just be so many social complexities that as a team, we might feel like we're constantly putting out fires. And the family as well constantly feels like they're just jumping from one fire to the next. And it can feel really difficult to talk about transition when you're trying to talk about where are they going to live, right? And I think that it's really important to include those issues of, transition. So that is it for me, just remembering why we're transitioning people, having a system so that we can send people off in a positive way. So that's it for me. Thank you.
Hi, everyone. Let me just share. Okay. My name is Lindsay Barkoff. I am one of the pediatric heart transplant nurse practitioners, and I've been here for about 8 years. Here are my objectives. I'll provide an introduction, give some definitions, talk a little bit about who these patients are, provide some background, talk about why transition, barriers to transition, how to transition, including our own transition process, and a conclusion. From a regulatory perspective, a heart transplant patient must always be under the care of an official heart transplant program, along with the help of my fellow nurse practitioners, physicians, pharmacists, social workers, child life, child psych, and dietitians. We care for about 190 pediatric heart transplant patients. Roughly 64% of them are over the age of 12 and somewhere in the transition process, and 30% are over the age of 18. The timeline of when these patients should transition their care to adult programs is really individualized, but we typically introduce the concept to our patients and their families around age 12, with the eventual transfer of care somewhere between age 20 and 25. Poor adherence and bad outcomes are everyone's worst fears, but hopefully at the end of all of today's presentations, you all will have a little bit better of an understanding of how to transition these patients. Let's see. Going forward. Okay, there we go. You've heard some of the definitions already, but as a field, transition is relatively new. It was first introduced in the literature beginning in the mid-1980s, but was not formally defined until 1993. Transfer is sometimes used interchangeably with transition, but it's really a step within a larger process. Since 2010, there's been a larger effort by many experts in the transplant field to come together and transition this complex group. So who are these patients? Just prior to the COVID-19 pandemic, I received a pretty typical voicemail from one of my patients, a 29-year-old combination of heart-liver transplant, who also had chronic kidney disease, restrictive lung disease, hypothyroidism, migraines, a combination of depression and anxiety, and an overly involved helicopter mother. She was calling to inform me that she'd run out of her Lexapro. Oh, and by the way, what birth control would I recommend? Yes, I could counsel her on safe sex practices and birth control recommendations, but knowing this patient, I realized where these questions were coming from. She really wanted to discuss the possibility of potentially becoming pregnant in her future. I had just come from clinic where I had seen a 3-year-old where we talked about developmental milestones. I couldn't help but think it was time for this adult patient to transition her care. She was already seeing adult neurology and adult endocrine for insurance purposes. So how big of an issue is transition? This study shows that somewhere between 15 and 20% of all adolescents in North America live with chronic diseases. A significant majority, with some estimates reaching 90%, will require ongoing care as they approach their adult years. The American Academy of Pediatrics published that up to 83% of adolescents are not sufficiently prepared for transition to adult providers. A chapter from the textbook on organ transplantation writes that as survival for pediatric transplant has improved over the years, there are some estimates reaching 95% 10-year survival across all solid organ transplants. This population will have adult needs and should transition their care to adult providers. However, this study showed that only 50% of all pediatric heart transplant patients will transition their care to adult. Why transition? It's essential. It deals with the intersection of psychosocial, medical, and logistical needs. It's not a one-size-fits-all kind of process. Many of our patients have intellectual disability, global developmental delay, and will require ongoing support from their family as they receive their care. Some of our patients might never reach any degree of independence, but will ultimately develop adult chronic conditions that will require care. From a psychosocial perspective, Amaral and Bell comment on the importance of discussions around sexual and reproductive health, drug and alcohol use, anxiety, depression, and general healthy living topics. And this patient population might feel more confident or comfortable discussing these topics in the context of their transplant team. In pediatrics, so much of the focus is on developmental and scholastic milestones. These larger medical and psychosocial issues are much better served by adult providers. And beyond counseling about safe sex practices, what about pregnancy management? While it's infrequent and high risk, Lynn Kunoz in 2020 comment on 91 heart transplant patients and 157 pregnancies in a 2020 paper. In terms of logistical considerations, insurance varies greatly from state to state as these patients become legal adults. And ultimately, this can affect their access to care. A 2017 paper by Dimitri Tuning and colleagues found that any lapse or change in insurance can affect long-term outcomes in adolescent heart transplant patients. As adult patients are forced to lose their pediatric insurance plans, it's important to set them up for success with adult providers, which will ultimately allow them to maintain access to medical care. And furthermore, even if these pediatric patients are able to remain within their pediatric programs, it's likely that other specialties who follow many of these patients will have a firmer age cutoff and will no longer be able to see these patients. This will result in fragmented and disjointed care, similar to my patient LE from the beginning. I think we have all seen poor outcomes with inadequate transition, but it might be difficult to pinpoint the exact cause of these poor outcomes. Are they a result of not providing enough education to these families and our patients, not having ongoing assessment of this education? Is there poor communication? Was the patient transitioned in another period of transition in their life, like instability with life, with jobs or school or housing or insurance or financial issues? Are they experiencing some exacerbations of their mental health disorder? These all appear to be modifiable risks that can ultimately improve the quality of life for these patients. What are the theoretical barriers to transition? They really stem from three different vantage points: the patient, the parental, and the provider perspective. The AAP states that the most common barrier to successful transition from the patient perspective is the familiarity with the transplant team, just the comfort and relationships developed over the years. A systematic review of the literature from Wendy Bray and colleagues in 2017 found that, again, relationships were noted to be the most widespread barrier from the patient's perspective. The relationship between a transplant adolescent and their patient is complex. I love this caption. At some point we have to stop swaddling him right. Stevens and colleagues in 2021 writes about transition barriers from the parental perspective. Quote, Parents might have feelings of guilt over their disease. They can have difficulty in letting go over their child's care and perceive them to be more fragile than other children. And from the provider perspective, the strongest barrier to successful transition is, according to the AAP, is inadequate communication, coordination, and collaboration among the programs. Our transition process for our patient population is a little bit of a work in progress. We do introduce the concept at around age 12 and once someone is a year out from their transplant. COVID, like for so many of us, has changed many of the ways that we deliver care to our patients, and not surprisingly, this has affected our transition process as well. After its introduction, we provide this track questionnaire mentioned in other talks today. We increase the frequency as a patient approaches their care transfer. Our psych team will score the track form, help identify goals and any barriers, the higher, and then document it in the chart. The higher the score, the more the patient is seemingly ready for a transition. Another important milestone as a patient approaches their care transfer is to meet with the medical team independently of their parents, which often is hard for both patients and their parents. Here's an example of a track form filled out by one of our patients. It has a score of 87. So this is a 16-year-old who is several years out from his transplant. He expressed being so far out from transplant that you, quote, just kind of get used to it, referring to the emotional impact of transplant as well as its impact on his daily life and routine and taking medications. His transition goal was to set an alarm to take his nighttime meds with mom as a backup to remind him. He denied any mood or anxiety concerns. And this patient is our one exception to our strict transition age policy. He was co-managed by Kaiser. And so once a Kaiser patient turns 18, they transfer their care. This second example, it was filled out by a 14-year-old who was also several years out from his transplant. This track form had a score of 60. The patient denied the opportunity to meet with the psych team independently without his parents in the room. His transition goal was to, 1, watch mom call to make appointments, and 2, watch dad call to make medication refills so that he over time could become more comfortable with that. He denied any mood or anxiety concerns as well. We also use this EPIC flow sheet to document transition stages in terms of when topics are introduced, attained, and mastered. These phases are not related to age necessarily, but move along in a sequential order. Stage 0 at the top indicates that a patient is not eligible for stage-based assessment. Reasons for this include being too early from transplant, global developmental delay, or medical fragility. Stage 1 is really the beginning of transition. It's empowering the patient to know a little bit more about their medical history. We get them to understand why they had a transplant, when they had a transplant. I will often ask these questions as, well, why do you come see us here? What's unique about you? Why do you have to come see us in this clinic? It's getting them to know a little bit more basics about their medications in just general terms. So how many pills of this medication do you take? How many times a day? Stage 2 through 4 builds on this knowledge, allowing them to gradually be more independent, with stage 4 being the last stage before someone is ready to transfer care. Ideally, as a patient moves further along in their transition stages, there's a collective discussion with the patient, with the parents, and then with the team to move them towards transfer of care. While transition here is relatively new and still sort of a work in progress, I think we can look to the literature for how to improve our own approach. Loss to follow-up rates for this medically complex population can lead to poor transplant outcomes. However, despite all of these challenges, there are a growing number of studies on successful transition. This paper internally reviews their own transition program. It's based heavily in education. The program has adolescents meet to discuss their own indications for transplant, as well as medication specifics, risky activities, ways of managing stress, insurance and financial issues related to transplant, as well as an introduction to local adult providers. Their process incorporates the caregivers as well, the parents who have a parallel curriculum learning all of these same topics. And it includes the multidisciplinary team because they are an important part of the transition process as well. The group found an increase in overall medical knowledge from the beginning to the end that was statistically significant. This was defined as stable immunosuppressive drug levels, which could ultimately lead to lower adverse events such as transplant rejection, graft loss, or death. And while it was only a single center study, it's a good example of what other programs, what we could potentially implement. This pilot transit study was innovative. It was the first randomized control trial for pediatric heart transplant patients going through transition. It compared two different processes of transition while focusing on transplant knowledge, advocacy, support systems. The study also found a significant percentage of this population lacked an understanding of their transplant, had a difficult time understanding their transplant medical needs, had a difficult time navigating the complex medical landscape and insurance issues. Even though the results did not necessarily demonstrate improvement in long-term outcomes, it did validate that transition is achievable. With transition being a relatively new field, as more and more adolescents approach their adult years with adult needs and chronic conditions, I think we can also look to other conditions such as cystic fibrosis, which I think has demonstrated such a great way of transitioning their complex patients. I don't think we need to reinvent the wheel. This paper focuses on transition for pediatric diabetic adolescents, which showed there was up to 60% loss to follow-up rates with this population. This transition process focused on efforts to improve medical knowledge, support, and communication pre and post transfer, which ultimately resulted in better long-term outcomes for this population. This study reported on a larger cohort, 137 liver transplant patients living in the United Kingdom. The group transfers patients when they're ready, regardless of age, and there is a facilitated visit between adult and pediatric programs to help with this transition process. They had an almost 94% 5-year survival and nearly 90% 10-year survival post-transition. So in conclusion, transition is overall possible and should happen for these young adult patients. It's important to start the conversations early and discuss them often while providing ongoing education and assessment. A formalized and consistent transition process can lead to better long-term outcomes. We definitely have ways to go with our transition process here. It should not necessarily be defined as an age cutoff. One size does not fit all. Adult patients will have adult needs. The best chance for success is to have a transition champion. It's important to work within the multidisciplinary team, like our social worker, psych, to ensure that all areas of care are met. Communication is essential. And with improved survival for this complex population, there are additional clinical trials needed to better help address the complex needs for this population and to standardize this transition approach. Thank you.
Hello, I'm Pam Simon, and I am going to share my screen real quick here so we can get started. And finish up. So I'm going to finish up the talk. And as my colleagues so eloquently showed, there's a lot of principles and standards that can be set up for transition to adult healthcare for our adolescents and young adults in many specialties. I'm going to talk today specifically on childhood cancer survivors. We're a little more in our infancy when it comes to childhood cancer survivors. And I'll show you some nuances, and that's really what I'm going to sort of focus on today is these childhood cancer survivors and how some of it's the same as we've heard today, but that there are some differences as well. And so I'm going to talk a little bit about, use a case study to illustrate transition issues for adult survivors. We'll talk about some statistics, identify late effects of these survivors and what problems they have, as well as their transition issues and concerns. So DL is a 23-year-old male. He was diagnosed with mixed phenotype acute leukemia at age 17 years old. He underwent chemotherapy, radiation, and a stem cell transplant. So some of the things for him, when I saw him in survivorship, obviously he was already 23 and he was only about 5 years out from ending his treatment. And so that's one of these issues with our childhood cancers, unlike cystic fibrosis, where they're diagnosed at birth and you can continue that education throughout their lives. Our patients may be diagnosed at any age. They may require treatments that go through different stages of their life. And so having a standard sort of age to start transitioning can be a little more difficult, which is the case for DL. Some of his issues, he really didn't have a whole lot of effects from his transplant, which was wonderful, but sometimes can also make it more difficult. He had infertility. He didn't really understand the impact of that. He didn't really understand what happened. He had collected sperm prior to his transplant, but there was no sperm in the collection, and he had not been told that, or he didn't remember. He didn't really have any follow-up from a perspective of coming back to his appointments for his iron overload. He needed, due to all the transfusions he had iron overload and required phlebotomy monthly. He had not been coming to those appointments, and he had not been getting his phlebotomy. He was reluctant to transition. He gets along. He's one of those superstar patients. Everybody loves him. And he's wants to be a mentor for other patients as well. And so really enjoys the pediatric world. And so he, didn't really want to transition. So we had to really start talking about that process. We talked about insurance because though he could be on his parents' insurance until 26, he was getting closer. And as a cancer survivor, what did he need to know? He also, from a psychosocial perspective, he had a lot of anxiety, PTSD, and really didn't want to leave home. He finished community college. He was able to graduate from college. He got into graduate school, but he just kind of was stuck. He didn't really know what he wanted to do next. He didn't, like I said, didn't want to leave home. And so you can see how when the cancer diagnosis and treatment happens, especially with developmental milestones, can sometimes be an issue for these patients and interfere with transition. So let's talk a little bit about statistics for the childhood cancer survivors. So the good news is there are a lot of them. Their survival rates are improving. As you can see, it's greater than 80% for a 5-year survival rates. And so there's a lot of them, and they continue to get older and need transition. 70% of these survivors are 20 years and older. And so transitioning to them to the appropriate healthcare providers in the adult world is important. Unfortunately, many are lost to care. And so one study showed that half of the patients return for their follow-up 10 years after completion. And so I think the most concerning statistic is that 98% of adult childhood cancer survivors had at least one chronic health condition, and 67.6% had severe or a life-threatening condition. And so they do have issues, and they do have concerns from their treatment. And unfortunately, often these don't occur for 20 to 30 years after treatment. And that is where transition is vital. So it really is vital for these patients. When we talk about what types of problems they have after treatment, it's multifactorial. They get chemotherapy, radiation, and surgery, often all of them, or a combination of them. And these are intense treatments. They're given to often small and growing children and adolescents, and they can cause late effects. And we don't want to forget about the psychosocial and quality of life outcomes as well that we see in our patients. Here's just an example of some of the medical, cognitive, and psychosocial late effects that we see in our patients, and they can stem from anywhere, any part of the body, including the psychosocial piece. And so as you see with our patients, as many other specialties, they require different types of specialties. So often our patients are still seeing oncology or transplant, bone marrow transplant specialty, but may have already transitioned to the adult cardiology or the adult endocrinology, because each one of those specialties have their own standards for when they transition and won't see the patients or in cardiology, for instance. So our job as the oncology survivor clinic is to really help them figure that piece out, as well as their primary care. And we'll talk more about that in a minute. So here's some of those important issues that affect these childhood cancer survivors. Obviously, insurance. Of course, there's the law that requires that, they can't be, denied insurance is wonderful, but they often don't understand at 26 or whenever I choose my insurance, how's that going to affect me? Maybe I won't be able to see the providers I want to see or need to see. And so helping with that. Education, career, people have mentioned this already today. This is a busy time. Adolescent, young adults, when we want to transition these patients, they're geographically mobile. They may not know where they're going to live. They know not what they're going to be. And so transition can be difficult. Especially in oncology, the adult cancer system is not set up for this population. The adult cancer system is set up by disease. It's not set up for childhood cancer survivors. And so it's difficult to just transition them to an adult oncology. There isn't an equivalent. Primary care providers, this is really the crux of childhood cancer survivors, is them finding a primary care in the adult world that they trust, that understands what their cancer history means to them and what risks they have going forward. And I'll talk more about that. We talked a little bit about psychosocial, but often anxiety about their cancer history can influence their willingness to seek care. And they may have not worked through what they went through, or they may not even remember their treatment because they were too small. So the other thing that's a good thing is that these, excuse me, these young adults are often healthy. Like I said, they may not have these effects for years down the road. And so they don't feel like they need to. They're invincible. They don't need to go to the doctors. And then that trust and bond with the pediatric team, which we talked about already. So it's very critical for our patients to receive risk-based care. And this is the screening, prevention, and treatment of late effects throughout their lifespan. Here's just a few examples. Hodgkin's lymphoma patients, for instance, they have an increased risk of lung cancer due to their radiation. Females who have been treated with radiation anywhere to the chest area are going to be at risk for breast cancer. So they need to start breast cancer screening very early. And then leukemia survivors, we found that they have a higher risk for obesity, osteoporosis, insulin resistance, and cardiovascular and cerebrovascular disease. One of our tools that is specific for cancer is something called Passport for Care. And this is with the Children's Oncology Group. They have survivorship guidelines that provide us with this information. But the best part about this is that it gives a cumulative summary to the patient. So all of their treatment is in one place that they get access to. There's a survival portal for these patients. And then the other part is it gives the follow-up guidelines based on their risk from their treatment. These documents can be shared with their providers. And so that is a wonderful tool and something that we try to do early on so that they can start getting used to this tool. It also gives healthcare links to help them understand how to keep themselves healthy. And so we in cancer don't have as great of standards as the cystic fibrosis or cancer. We hope to do that at some day and are working on different types of standards. We do use the track assessment and things like that. But we don't have that standard for transition yet. But there are some models of care out there that we figure. There's a shared care where a primary care will take care of the patient along with pediatric or adult oncology survivorship clinics. And then for many patients, they hopefully could be completely taken care of by their primary care provider, as long as they the providers know what that risk-focused survivorship care looks like. Stanford Primary Care has just started a model where a few of their providers are trained in cancer as well as primary care. So they are taking only survivorship patients that have had some experience of cancer. These are wonderful types of models, and we hope that can continue and grow. There's also a cancer survivorship course for primary care through the Stanford CME. It's called Health After Cancer. It is mostly focused on adult cancer patients, but there is a module specifically on a childhood cancer survivor that helps to understand and teach about what are the survivorship needs of this population so that primary care is more knowledgeable and feels comfortable taking care of these patients. So our survivorship clinics are set up for educating about long-term effects, developing and implementing personalized follow-up plans for these patients. It's really important, as mentioned before, to educate our patients about their diagnosis and treatment. They may not remember. Their parents often are the ones who have all the information, and as previously mentioned, do most of their care for them. And so helping them understand how they can start managing their own healthcare and supporting them through that. That's the most important thing to a successful transition. So as mentioned, I manage the adolescent and young adult cancer program at Stanford, and we established back in 2015. Though I see patients at diagnosis during treatment, in survivorship is really where we focus on this transition to adult care. And so we do talk about what is your treatment, your risks, give them the passport for care, work that with them over the years. Try to start about age 17 if possible, if they're done with their treatment and they're ready for survivorship care. Like I said, that may be more in their 20s. Sometimes it's even late 20s by the time we're really transitioning these patients, and even in their 30s sometimes. And so we hope to get better at that and hope to have like standards, like I said. We do use the track assessment. We really work with the primary care doctors to establish care and continuity. Often, like previously said, waiting until they know a little bit more, when they're done with college, they don't have all these other big life events, sometimes makes it a little bit easier for them to transition to that primary care doctor. And then we're available if needed. And of course, if they have transplant issues or oncology specific issues that we need to see them for, we can continue to see them or transfer them to the adult oncology. But often these patients, what they need is primary care, a good primary care who understands the needs of this population. And then, of course, making sure the patient has these resources as they get older. So in conclusion, for adult survivors of childhood cancer, transition is vital, but it often can be a difficult process. We want to make sure we start early before the actual transition happens. As mentioned before, we don't have a standard model, but we hope that we can emulate cystic fibrosis and heart disease and start getting better at that. Risk-based survivorship is important in this patient. As I said, PCPs are really, in my opinion, the most important part of it, and make sure that our patients have their information. I think we're going to take questions from everybody now.
I've answered some of them. Chetwin Sarubi asked, how does transition work for children on Medi-Cal after CCS eligibility ends at 21 and they still remain on Medi-Cal without access to commercial insurance? I can talk for the CF patients. There's a GHPP adult version of CCS, Genetically Handicapped Persons Program. You can look online about that. Once they're 21, CCS does end. So we try to get the paperwork in at least within 6 months prior to them turning 21 so that there is no lapse in the state-funded insurance. If anybody else has any further answers over that.
For cancer, it can be a little difficult. They do lose their CCS, and so they generally go on regular Medi-Cal, but that education is super important to understand that if they sign up for a county-based, they may not be able to see their specialties like Stanford or different things like that, and it may dictate where they go. So I think education for them to understand what are the options, and we have some resources like Triage Cancer that have that type of education.
I was going to include that a lot of the CCS, a lot of the counties with CCS now have somebody who specializes in helping patients transition. And so I also do encourage families to talk with their insurance about transitioning, because a lot of times they do have somebody who can specifically help them with that.
Lindsay, this question would be for you from Albert. We have in our clinic complex congenital heart patients that have been operated on, unfortunately do not have an adult cardiologist who's interested or knowledgeable enough in looking after these patients. How do you suggest we start a program of transition in these cardiac patients?
I'll answer the prior question first. In terms of just CCS and aging out. It's a little different in our pediatric heart transplant population in that there are a limited number of programs. And as I mentioned at the beginning, someone who's undergone a transplant always has to be under the official care of a program. So yes, our patients, when they turn 21, will age out of CCS, but we incorporate our lovely social workers as well as our dedicated financial coordinators to work with families to figure out the best insurance plans for them going forward. But they will there are always sort of ways to navigate to make sure that they can always be under the care of a transplant program. The question regarding adult congenitals and how to sort of navigate that, it's a really good question. It might be worthwhile to again, you utilize your psychosocial support, your social workers, and your child psych. I don't know if you are able to do any psychosocial neurocognitive testing on this population, to set a meeting up with the adult provider to sort of lay the give the layout of all of these patients, but it might not work smoothly. It might just have to work from a bunch of different angles to sort of get to that place of being able to manage this population.
Next question is from Kay Burke. Family physicians can be the continuity link between peds and adult specialists. Shouldn't they be included in transition meetings? I will start that. Yes, that's actually a very good recommendation. I think the pediatricians that work with our CF patients are very engaged. It is very hard, especially for state-funded insurance patients that only have state-funded insurance, not commercial, to find primary care providers. In fact, before they transition, we really try hard, and the adult team for CF does try to find PCPs for all patients. But I think that is a very valuable addition. That's something to think about to add. Also, to add into the documentation, a lot of outside providers do have Epic. So thank you for that. Anybody
and I agree.
else?
I think pediatricians also can help our patients because they trust their pediatricians so much that helping them find a adult primary care is important, and knowing that transition happens from that perspective, even though, you know, specialists like us are seeing these patients, we can't forget that they have these relationships with their pediatricians who are very vital in helping with this transition.
I agree. And I think that pediatricians can sort of mimic the independent visits as part of that transition process to continue the ongoing discussions about what seeing adult providers might look like. And yes, your parents might still be able to be involved. But yeah, I sort of view primary care or family practice providers as an extension of our team for sure.
And there's two more questions left. One is from an anonymous attendee. I love the staged approach. Rather than framing it as transitioning, could it be framed as increasing in knowledge? For example, a 4-year-old may not know the ins and outs of their medical conditions, but each year they should learn a little bit more so they can positively impact the success of their care. That's actually another great suggestion. I do think we do start talking to children. Like I said, obviously parents at the first newborn visit, but even 2-year-olds or 3-year-olds, we start teaching them about little things. They already have to put a vest on, they take nebs, they take medicines. So they already know they're having to do things that other people, even in their household, other siblings don't have to do. Very good suggestion.
Yeah, and that was kind of what I was trying to say around like how I frame it, rather than talking about, I'm asking you these questions to prepare you for a transition. I do try to say, like, you know, we want to make sure you understand these things so that you can advocate for yourself and, you know, feel confident in your own care and knowing what your, you know, disease is.
Question. The last question is, what is the patient mental status with CF preparing for adult transition? It varies depending on the patient completely. We actually have mental health screen we do every year. Patients have to do that on their annual visit. So we are always tracking and following mental health on our patients. And if there's immediate remediation that needs to be done at the visit, we do that. If there's, we see a patient's at risk. But mental health is a huge part of our process in transition.
Yeah, I would agree. And we try to make sure that they're already connected to any mental health support that they need before they're transitioning. And if the adult side has mental health support built into it, then we want to connect them with that. I also think along with the mental health and just sort of the general comfort level of transitioning. One of the things I forgot to mention is I think patients find a warm handoff so incredibly helpful in feeling like, you know, knowing that their doctor, their pediatric team has spoken with the adult team that they're going to, I think really helps people to feel more comfortable and confident.
Yeah, and we walk the patients over to the adult side at their first visit.
Yeah.
Excellent. Such a great way to wrap up. I want to thank our incredible group of speakers for this session. I think there was a lot of information to digest, reflect on, and even some practical strategies to take back to your individual institution. So I just want to thank you so much for sharing your insights with us on this session. And I also want to thank our attendees and those that stayed in and waited, even though we're a few minutes over. We appreciate that as well. I thought that there were really great questions that they were able to answer. And just to wrap up, I wanted to remind you that we have an afternoon session today on care options for gastroesophageal reflux disease. And the week continues with 2 sessions on Thursday as well as on Friday. So thank you so much for attending and enjoy the rest of your Wednesday.
Bye.